This is called eJournal Club. This is the first of six journal articles that I will be engaging with an author of one of the studies over the next 6 or 8 months. And I kind of scoured the literature looking for something of high impact, high interest, and certainly the prize study, and the timing was perfect, New England Journal publication, Paul Emery, the first author, on one of the hottest topics in rheumatology, and that is stepping down or discontinuing therapy in patients who have achieved some form of treat to target. I don't have to tell anybody in this room what the ramifications are here. One, patients would like to take less medication. Two, in terms of affordable care, even decreasing the amount of a biologic for even a few months can have a profound impact on cost flows. So we have Paul Emery online. So Paul, can you speak up so we can make sure we got you going?
Yes, very pleased to be here or there.
Oh, great.
Wherever I am.
You are.
And,
There's
delighted that...
All right. So without any further ado, Paul Emery requires no introduction here. He is ensconced in the leadership of rheumatology trials in so many diseases, particularly rheumatoid arthritis, past president of EULAR, and Paul, without any further ado, I want to give you a good few minutes to go through your paper, and then we're going to open this up for discussion. That's the whole goal here.
Well, thank you very much, and once again, I'm delighted to contribute to your journal club. The whole idea of de-escalation, tapering, whatever it's called these days, is a logic that's been with us from the beginning. We're using an anti-cytokine, anti-TNF, or in this case a receptor blocker, which a receptor fusion protein. And the idea is that when you start therapy, there should be a lot of TNF around to block, and later on there probably is a lot less. So you could potentially and logically reduce the therapy. But it's taken a long time to reach that position, partly because we've always treated patients after they failed methotrexate, and traditionally those patients rarely get into true remission. So this is one of the few studies, which has been a long time in the planning, which took patients who were naive to methotrexate, treated them optimally in the phase 1, and then saw whether we could actually reduce therapy in a controlled way. We know that you get high remission rates with first-line therapy with combination methotrexate and biologic, and that's what we saw in this study. But the evidence up until now has been relatively patchy and difficult to interpret because most of the studies haven't been controlled studies. So we were keen to see what particularly Etanercept could do, because the other studies we've been involved in have been with monoclonal, and there's always been some debate about whether there's a dose effect or whether it is the effect of a monoclonal that does allow one to reduce therapy later. So if we move to the next slide, which is the study design overview, and this is probably the most important slide in understanding the study. The phase 1, the open label, in the New England Journal paper is not commented upon much, but I think there's quite a lot we can learn from it. But essentially, patients had a standard approach, which was Etanercept 50 milligrams a week plus methotrexate, which was escalated in a standard fashion up to a maximum of 25 if they needed it. And a responder was defined as a DAS less than 3.2, that's low disease activity at week 39, and having remission by DAS, which is less than 2.6, at the year point. So the patients who'd had nothing worse than low disease activity for the last 13 weeks. Those of you who follow the literature will know the Optima study, which was slightly different, and they actually took patients who responded very quickly in the first 6 months. We've tried to do an analysis to compare the two, and it's not complete. But just to realize that many more patients went into the second phase the dose reduction phase because of a longer period of observation prior to that. So the second phase, which was double-blind, was a dose reduction for all arms. The etanercept dose was halved in the first arm. The etanercept dose was stopped in the second arm. And in the third arm, both the methotrexate and the etanercept were stopped. So it's half dose, no biologic, and no therapy with the three arms. And that was double-blind. And then, if they were appropriate, the patients then went into an observation study where they had no therapy at all for the last period. So we move to the next slide, which is LDA remission and complete response at week 52. The first bit on the build is the green columns, and they are the last observation carried forward. And the first thing to say is that 70% of the patients, even on an intent-to-treat basis, achieved remission, which is one of the highest remission rates, but is entirely consistent with two other studies we've done, one of which is COMET, where patients treated in the first 4 months of their disease since diagnosis also achieved a 70% remission rate. Another double-blind study called EMPIRE, which was virtually identical as well. So it's now quite consistent that etanercept treated as to methotrexate naive patients in combination with methotrexate produces the 70% response rate. Now the second build is the brown bit, which is actually the completer rate. And what you see is that low disease activity is achieved in virtually everybody that completes, which is 97% of SDI-LDA and 96% of DAS-LDA, which is relevant because people say that rheumatoid is a heterogeneous disease and doesn't respond to a single cytokine inhibitor. But I think you'd accept that a 96% response rate of completers suggests that if you tolerate the drug, because most stopped it because of a side effect or intolerance, it suggests that there is, at the start of disease anyway, a fairly consistent TNF dominance. There's a final little column, which is the complete response, which is the highest level, which requires not only a DAS less than 2.6 and a HAC less than 0.5, but also no change in X-ray over 52 weeks. So that's what happened in the first period, which isn't described really in the New England Journal paper. Then we go to the next slide, which is the ACR Boolean remission. And this is taking patients who achieve Boolean remission, what happened to them when we put them through phase 3. And the first line is the patients who had placebo, and you can see there's a reduction to about 20%. And this is a common factor when you stop therapy in established disease. Suddenly, you get about 1 in 5 who remain in remission. If you look at those who continued methotrexate, about 50% stay in remission. And if you look at the half dose, virtually everybody stays in remission. There's virtually no drop-off at all, which I think has some significant implications for how we manage patients who are in remission. If we look at the HAC, which is an important patient-reported outcome, we see the same, but there's much less drop-off. And for both methotrexate and the half-dose etanercept, there's rather little drop-off at all. So patients who achieve a normal HAC tend to maintain it. Again, I think that has implications because although you can stabilize HAC later, it's very difficult to normalize it and probably means that we should be aiming for a normal HAC from the beginning and using what it takes. In terms of radiographic progression, this was a surprise to everyone. And what you see when you do the build is there really is no change in radiographic change at all. And this is slightly different, and it's that you've got the open phase, which is, don't forget, everybody is receiving optimal therapy during that time, and there's virtually no change in X-ray. But after stopping, surprisingly, there is no further change in any of the three groups, which is important for the long-term prognosis of these patients, as we know that the radiographic change is highly predictive of functional change in the later years. And it does appear, therefore, that the remission induction approach has managed to do something, whether it's stabilizing osteoclasts, but it's certainly doing something that has made radiographic change much more difficult. The next slide, which is phase 3, looks at Boolean remission in phase 3 in the 3 groups after they've gone through their double-blind phase and now have had all therapy withdrawn. The placebo arm really doesn't change much, still around 20% stay in remission. There's a big drop-off in the methotrexate, showing that methotrexate is having an effect in a substantial number of patients, and the etanercept drops off as well. But you can see that at the end of 100 and whatever it is, nearly 120 weeks, 50% of the half-dose patients who actually entered into the double-blind phase are still in remission. In other words, patients who had a year of full dose, a year of half-dose, 50% of, and it is of about 70% who went into the double-blind phase, so it's a third of patients are still in remission of the total that started, with a dosage regime which is about, well, certainly less, about a third of the cost of a full dose regime all the way through. So our conclusions from that are listed in the final slide, which I think is uncontroversial, as most of the conclusions are. So you get a high level of remission with the combination, significantly lower proportions of patients with the monotherapy and placebo in the double-blind placebo stage, in the double-blind phase. The radiographic progression, as I mentioned, was stabilized. In the phase 3, there were declines in the remission rate, but significantly more sustained the remission in the group that had reduced dose combination in the phase 2 compared to those that were in the placebo group. And the final bullet point is the suggestion that if you get a substantial remission early, and it is at least low disease activity for the last 3 months, it is possible to reduce biologic or withdraw it for many patients. And I think this is something now that is becoming part of the standard of care for patients. Although the proviso, of course, is in these patients, they did receive the biologic as their first DMARD. So I'll hand that back to you, Len, and for discussion.
Okay. Well, I think here's how we'll do this. I'll transmit the questions here for anybody. I mean, there's so much. I'm going to take a prerogative here of asking the first question and then open this up. There are numerous other studies at ACR that had looked at varying strategies, but this study is distinguished because of its early onset of disease, aggressive biologic use. Could you just comment in very global terms the German retro study, which it was more of a real-life study and not early. They still showed similar kind of trends here. Can you compare and contrast the differences between treating very early and treating established disease?
Yeah, we did a study probably 10 years ago, which looked at the difference between patients who had established and early disease with biologic treatment. And now the criticism of my study would be that our established patients have to fulfill nice criteria, which means they have to have 2 failures on DMARDs and have a high DAS before they go into it. So they already have residual damage. What we found in that study, comparing stopping, we were able to stop, this was with infliximab actually, but with infliximab, the early patients had about an 80% success on stopping it, and if they required restarting or regained therapy, and some regained therapy, remission with very little therapy, not even reintroduction of biologics, whereas the patients in established disease eventually all failed, and not all were able to reproduce remission. Now that was the criticism of that, as I said, is that that's fairly extreme. And I think probably nowadays, with rapid use of intervention when you're failing methotrexate and use of biologics, lower levels of DAS, the difference will be reduced. and that's certainly the finding. But in Europe, what we're spending most of our time on now is actually identifying which factors there are that help guide what is going to be successful reduction or not. And the things we're using largely are imaging and immunology. And what we found in our original study, if there was a normalization of T-cell immunology, you had a very high chance of being able to stop therapy. The trouble is, in late disease, rather few patients actually normalize their T-cell biology. What we've also, a Japanese fellow of mine, when he went back to Japan, actually did a study which was published last year in Arthritis Care and Rheumatism, and showed that the key factor in his population on stopping biologics in patients in remission was the presence of power Doppler, which was much more predictive than a very low DAS or any other clinical measure. So I think the fact is that early disease is effective, and it's effective because it switches disease off more completely. When you have late disease, established disease, you have damage, you have abnormal joints, and actually using abnormal joints will induce, through stress responses, cytokines, which sort of reactivates the disease. So the key probably is being able to switch off the immunology and also doing it at a time when your anatomy is near normal.
Questions, comments? William? That was William Rigby in the back, and he was commenting on the observation that radiographic progression was not seen in any group. And, you know, what are the ramifications for, how would you? Follow-up imaging. For follow-up imaging. And I mean, it's kind of surprising, as you said. What are your insights into this at this juncture?
Well, we know if we look at patients treated late in our standard fashion, that patients on biologics, particularly largely TNF inhibitors, do have quite a lot of what we would call predictors of erosions, in the sense they have high power Doppler, and those patients, when you take TNF away, do erode. I think this study was unusual because we don't know, because we didn't do ultrasound in this study, but the assumption must be that we switched off a lot of the underlying inflammation for which power Doppler is a surrogate, and that we were able, for a period of time, and I suspect it wouldn't go on forever, but it's given you the chance that if you, once you've actually done that, and you've, in a sense, with an oncological analogy, debulked disease, then it's going to be a lot easier to control. If I'm allowed an anecdote, we did a study back in, well, we did it in 1998, but it was published in 2001, and then the follow-up much later. The patients from that study, which had infliximab the moment they presented to us, with a matter of weeks of their disease starting, all seropositive, all had ultrasound imaging, they switched off their disease dramatically early, and we have found with now 10, 12-year follow-up, that these patients are still in remission and very easy to control if they have flares. So it seems that not having the bulk of disease and the circulating abnormalities that you have in rheumatoid can be achieved with very early use. So to answer Bill's question, I would suggest that we probably induced a sort of holiday period where osteoclasts are less active. I would bet, though, if without any further therapy, a proportion of those would become active. And I suppose if you were in an ideal world, you would be watching them with ultrasound, because when we don't see power Doppler, we don't see erosion, so we could actually monitor them subsequently. It's hard work doing that, but I think if we're thinking of using biologics early, the cost of them, then it would be justified.
John? Okay, so that is a good question. It's John Tessar. So the design of the trial was in the half-dose group of biologic, people did quite well, but some people did fall out of remission. What was the experience in this overall group of recapturing a targeted therapy, remission, or whatever? If you...
Yeah, that's obviously a crucial question, because if everybody regained remission, then you'd have no qualms at all about stopping or reducing therapy. And I think the current thinking is that reduced therapy is rather easy to regain flares with, stopping less easy. However, if you look at the data, it's completely mixed. Some studies say everybody regained their remission, which I find hard to believe. I've already said that our experience in late disease, when they flare, is they're much more difficult to regain remission. This study did not look at the dropouts and whether they regain response. Fortunately, in the half-dose arm, there were relatively few flares. There were, of course, many more in the when it was completely stopped. The study that's going to answer it, at least for another agent, will be AVERT, where the follow-up includes very precise monitoring of how well patients regain remission. But I think it's going to be that aspect which will dictate a pragmatic approach, because everything we do, we've just been doing some more recommendations. When we recommend anything, it has to be a joint decision with the patient. And the patients, my experience, the only patients who really are aggrieved are the ones that we did in established disease many years ago, who never got back to the same state. It's a very big moment for a patient, if they were in remission, to never regain that state again. So it shouldn't be underestimated. And I think to actually plan an algorithm for stopping or reducing therapy, a key factor is the risk of never regaining the previous state.
Paul, I'm going to ask one additional question here about you've mentioned several times about the use of imaging as a surrogate. Exactly, in terms of what type of imaging and what type of signals would predict success or failure in this? What can you summarize in terms of your observations?
Well, the comforting thing is that when patients are on a biologic, it doesn't seem to matter hugely what they've got, because it seems to be under control. Whether that's an effect on rank ligand or not, we don't know, but it has an effect of reducing the correlation between inflammation and damage. That's clear. We know that the best predictors of patients in DMARD remission, it's very straightforward. There's 10 studies showing this, that if you have power Doppler in an individual joint, that increases the risk of an erosion in that joint by approximately 10 to 12-fold. In fact, the risk factors are pretty consistent for that. When you stop, we would assume that power Doppler is going to predict flares, and it has done in DMARD. It does in DMARD patients even without conventional DMARD patients without stopping, and one would assume that after the period of time where the TNF wears off, that the same would apply in patients who had previously been on biologics. So we're getting better at predicting it. There's a number of studies in progress which will give much more precise information, but I think that's a sort of general summary of where we are at the moment.
And when you're doing ultrasound in this fashion, when people are basically in clinical remission or Boolean remission, you're doing a screening like 20 joint ultrasound?
There's a lot of debate about how many you need to do, 7 joints. Some people have even used a target joint. Tenderness still is probably the best indicator where there's likely to be inflammation, even if there's not swelling. Most of the time, in remission, a reduced number of joints, including the key ones, the MCP and wrist, and possibly the MTPs, is enough. You don't need to do all of them because it is a systemic disease, and on the whole, there is a reasonable correlation. If there isn't, it's in the seronegatives, but then you tend to have a swollen joint to look at. But in patients who have no swollen joints, it's reasonable to look at the ones that erode most, which tend to be the MCPs and wrists.
Okay, so well, Paul, I want to thank you for setting up this meeting. We have a great program. We wish you were here. It's a beautiful day here, and we genuinely appreciate your contribution. So you have a nice Saturday evening, and we're going to go to work here. So thanks again.
Many thanks, Edison, and thanks for the invite.
Great.
And from frozen Britain, good luck.
All right, thank you.